Welcome to the Smart OB-Med curriculum. Social media for advancing residency training in obstetric medicine. We here present to you a national collaboration between the Universities of Ottawa and Alberta. This research project has been generously funded by the Department of Medicine at the Montfort Hospital, empowering future physicians in the care of medically complex pregnancies. We hope you will enjoy it.
Welcome to the Advanced Learner Series. My name is Sarah Elias. I'm a GIM Internal Medicine Fellow, and we have the pleasure of having Dr. Malcom and Dr. Keely here with us today. Dr. Erin Keely is an endocrinologist at the Ottawa Hospital and full professor in the Department of Medicine at the University of Ottawa. She is a former president of the North American Society of Obstetric Medicine, past chair of the Canadian Diabetes and Pregnancy Interest Group, and co-author of the Diabetes Canada Diabetes in Pregnancy Clinical Practice Guidelines. In recognition of her contribution to the medical care of pregnant women, she received the North American Society of Obstetric Medicine Lifetime Achievement Award in 2019. In her spare time, Dr. Keely can be found on the golf course trying to improve her score or enjoying her new role as a grandmother. Dr. Keely, what's your favorite activity to do with your grandchildren?
Well, we're lucky enough to have them sleep over once a week, so that's my favorite, is having them stay overnight and having lots of fun.
I'm sure they keep you on your toes.
If only they'd sleep a little bit better, it'd be great, but yeah, they're good.
We have Dr. Janine Malcom. Dr. Janine Malcom is an endocrinologist and associate professor and clinical investigator in the Department of Medicine at the University of Ottawa. She is vice chair for the Quality and Patient Safety and director of Equity, Diversity, Inclusion, and Accessibility. She is a leading expert in the care of patients with diabetes in pregnancy and has contributed nationally as a member of the expert committee for the 2018 Diabetes Canada Practice Guidelines, amongst many other accomplishments. In her spare time, Dr. Malcom can be found on her Peloton or planning her next abroad adventure. Dr. Malcom, where is your next abroad adventure?
My next adventure is going to be Vienna and going to Budapest and Salzburg. So I'm excited about that. And also out east.
That's amazing.
And at Green Gables.
I'm a bit jealous, I'm not going to lie. So let's get right into the case. So we have a 25-year-old female, G3A2, at 24 weeks gestation. She is transferred from a smaller center to her high-risk combined obstetric medicine and maternal fetal medicine clinic for co-management of her type 1 diabetes in pregnancy. She was diagnosed at the age of 15. She has no microvascular or macrovascular complication, but she continues to have management challenges with periodic episodes of DKA throughout her pregnancy and before pregnancy. She is on escitalopram for depression and has been off her Vyvanse for ADHD since she found out she was pregnant. She remains on multiple daily injections with long-acting Basaglar and carb-counting ratios with her meals, which has recently been tightened to 1 unit for 3 grams of carb, as well as a correction scale. She uses a Dexcom for continuous glucose monitoring, and her time in range is 60%. She has had multiple episodes of DKA preceding this pregnancy, and one last week for which she was admitted for 48 hours at a peripheral hospital. She continues to struggle to manage the diabetes, especially in pregnancy. Type 1 diabetes can be so challenging to manage at baseline, but especially in pregnancy. What are your recommendations to this patient to minimize her risk of further episodes of diabetic ketoacidosis?
Yeah, I think the first thing you want to do is to really understand the root cause of her diabetic ketoacidosis. So she's working hard. She's wearing a Dexcom. She's taking multiple doses of insulin. She's counting her carbohydrates. but she's still ending up in DKA. And I think you have to give her space to acknowledge why that might be, because it could be cost. So if she has a Dexcom, assuming that that's being covered for her, but as your insulin requirements go up in pregnancy, the cost also goes up. It could be that she feels she's doing something wrong to have to increase her insulin doses, and she doesn't want to do that. And so you need to help them understand that's normal in pregnancy to have to take more insulin. It's not because you're doing something wrong. And then there's things like food aversion. So if you're nauseated and not wanting to eat, and you don't have a really good grounding in sick rules, you may omit your insulin because you're not eating, which can lead to DKA. And then lastly, there's a whole bunch of things that can happen behind the scenes socially. So from substance abuse to poor living situation to food insecurity, which can also drive the behavior. So most people don't want to end up in DKA, and there's usually a root cause to it. And helping to understand that root cause then helps you troubleshoot and come up with a solution for them.
She's now readmitted at 32 weeks of gestational age with general malaise, nausea, and 2 episodes of vomiting. Within the span of a few hours, her labs quickly progress. She has a metabolic acidosis with an anion gap that goes from 14 to 19, and this is associated with an albumin of 31 and a beta-hydroxybutyric acid of 5.83. Her glucose is 10.6. She did not skip any doses of her Basaglar, but she was not taking much of her rapid-acting insulin in the past few days, as she has very poor appetite. She has no infectious symptoms, her vitals are normal, and her physical exam is normal, outside of mild bilateral pitting edema. She has started on the DKA protocol, her anion gap closes, and no precipitants are found. She is transferred to the obstetric ward, and her Basaglar dose is reduced to avoid any hypoglycemic episodes. She is approximately on half of her Basaglar dose compared to what she was on during her 24th week of gestation. Her anion gap opens again. On further probing, we find out that she has almost eaten nothing over the course of the last 72 hours since being on the DKA protocol. And she has no appetite, although denies any significant nausea. Her anion gap reopens, and her beta-hydroxybutyric acid is elevated at 4. Her glucose fluctuates, but it generally remains between 4 and 10. Do you think this is starvation ketosis or diabetic ketoacidosis? And what features can help us differentiate?
So I think it can be difficult to really differentiate, and I think the thing that's important to know in this person is she's got type 1 diabetes, her insulin doses were decreased, so you definitely need to think about treating and managing as DKA. But if you were sort of to kind of compare the two, in general, starvation ketosis may be a bit milder. If it's a person who's not living with diabetes, often it's resolved by just giving them carbohydrate. They wouldn't go on to the full-blown DKA. And this person, it may have been the thing that kind of triggered her problem in the first place. She wasn't eating enough. That sort of started her cascade, and then she kind of got worse as she got progressively more acidotic. But I think in this case, definitely managing her with the DKA protocol, but ensuring she's got the glucose on board. And then sort of, once she's resolved, really looking at, why is she having so much difficulty with eating? Does she have some gastroparesis? Has she got nausea and vomiting of pregnancy that we need to manage? It's something that she's able to kind of keep her carbohydrate down, and then obviously making sure that she's on the doses that work for her to keep her within euglycemia.
Just maybe jump in. It's harder in pregnancy to tell the difference because their glucose will be lower when they're in DKA because of the renal threshold. So in the non-pregnant person, you would expect the glucose levels to be different. So they'd be more hyperglycemic if it was DKA. But in pregnancy, it's harder because their blood sugar may not be that elevated. It'll be elevated, but won't be 4 usually. So that would be unusual, but it certainly could be 10 and still be in DKA. I think the other thing is potassium. So the potassium being high in DKA is because it's related to not having enough insulin as well as the shift from acidosis. But if I saw a high potassium, I might think more that it was DKA instead of starvation ketosis as well. But I agree completely with Janine. It's hard to tell, and if in doubt, treat them like DKA. You'll never go wrong treating them like DKA.
Right. And going into treatment a little bit more, what are the main treatment differences between treating diabetic ketoacidosis and starvation ketosis? Considering that in a case you might not think there's significant overlap. This is obviously a more challenging one.
Yeah. So, if it's starvation ketosis, then you definitely want the carbohydrate. You're going to need the carbohydrate followed by the insulin if they need insulin. They've got type 1 diabetes, and you'll need the glucose to kind of turn off some of that starvation along with your insulin. If it's DKA, as Dr. Keely said, often you really see that mismatch, right? So your acidosis may occur much more rapidly. You may have your hyperkalemia. And again, as Dr. Keely said, I think one of the big learning points from this is euglycemic ketoacidosis. It's very common in pregnancy. So seeing a normal sugar, if a person is sick, it does not rule out DKA. You have to really make sure you think about it and order those things to make sure it's on your differential. But then, again, same thing with managing DKA, your insulin and your fluids. Watch your potassium before you start giving your insulin. Make sure their potassium is adequate. And then, manage the way you would in a non-pregnant person. I think the bottom line is here, babies don't like acidosis. So the quicker you can get them out of acidosis, the better.
Right. What are some particularities about DKA presenting in a pregnant patient?
So the biggest one is the level of glucose, and so that they're not as hyperglycemic. And the symptoms mirror pregnancy symptoms, right? So the nausea, the feeling unwell can mirror pregnancy. So it can be less clear, are they symptomatic or not? The other thing is they don't have as much buffering, so they don't have as much bicarb, so they're more likely to drop their pH sooner. So they do get sicker sooner, and so they will have a more severe acidosis, even though the glucose level looks very reassuring.
Right. And I understand that can be further compounded by the underlying respiratory alkalosis of a pregnant patient, which can give very much a mixed picture.
Yeah, that's right. And that's part of the reason why your bicarb is probably a little lower to begin with, right? You're trying to offset that. Yeah.
Very interesting points. So she is offered a dextrose infusion as the leading culprit is thought to be starvation ketosis. She declines as she says the infusion has a risk of worsening her bilateral pedal edema, and she doesn't want this to worsen. So she settles for sipping juice, and over the course of 3 hours, she has a total of 45 grams of carbs via juice. Her gap closes quite quickly, and her beta-hydroxybutyric acid goes back to being undetectable. The dietitian met and counseled her the following day and kept a close eye and follow-up throughout the remainder of her pregnancy. Thank you both so much. This was a really interesting case. Dr. Malcom, can you please summarize for our listeners the key take-home points of this case?
Okay, so I think one of the key take-home points is a normal glucose in a pregnant woman who is presenting with symptoms of DKA does not rule out DKA. So you really do need to make sure you think about it and order your beta-hydroxybutyrate. I think if you're thinking about starvation ketosis versus DKA, again, making sure you do have adequate glucose in a person, with type 1 diabetes who could get very quickly. I would not start at the starvation ketosis. I would definitely make sure they also have, you're treating for DKA. But if they're not turning around, or their gap is opening quickly and they're not eating and drinking, then making sure that they have the glucose on board. And then finally, really for this, young person, as Dr. Keely had mentioned, really having a good talk with her and the multidisciplinary support around, what are the underlying reasons for why she's kind of flying back in and out? Why is she going to starvation ketosis? Is it, food restriction? Is it really that we're not managing her symptoms of nausea and vomiting? Is it that she has gastroparesis? And try and treat the underlying cause.
Thank you all so much.